Neuropathy project is the most reliable, unique and complete answer for the diagnosis and management of Sudomotor dysfunction in patients with diabetes. The first step of this project is Neuropathy test, a unique, innovative, validated diagnostic test for Sudomotor dysfunction and diabetic foot syndrome. The second step is Neuropathy repair foot foam. This represents the most complete and effective treatment for all diabetic patients with Sudomotor dysfunction who exhibit positive neuropathy results. Thus, Neuropathy project enables a move 2 steps forward in the diagnosis and management of diabetic patients with foot at risk of diabetes, and its complications may have several manifestations in lower limbs. Diabetes mellitus can involve virtually all the tissues of the feet, leading to serious pathology which may or not have recognizable signs and symptoms. The common etiologic factors of diabetic foot complications are peripheral vascular disease leading to ischemia, peripheral sympathetic dysfunction leading to dry, cracked skin, and peripheral somatic neuropathy, which is the most widely recognized component and affects both sensory and motor nerve fibers, leading to painful and/or insensate feet and foot deformity. The result of one or more of the aforementioned contributory factors in combination with trauma, extrinsic or intrinsic, is foot ulceration. Finally, the combination of ulceration and infection leads to amputation. Importantly, it has now been demonstrated that up to 85% of amputations are preceded by foot ulcers. Foot ulceration and amputation have major social and economic consequences for patients and their families, and they increase dramatically the costs of health care. All international diabetes or diabetic foot organizations agree that prevention is the most effective way of changing this situation to reduce amputation rates. Prevention has 3 major components. First, physicians should identify patients with diabetes mellitus and foot at risk of ulceration by comprehensive foot examination. Second, preventative education and appropriate foot care needs to focus on patients with foot at risk of ulceration. And third, multidisciplinary management and provision of care according to international recommendations for all patients with risk of foot ulceration. Neuropathy in general is the most common and important etiologic factor of diabetic foot lesions. It is a very heterogeneous disorder, but its commonest form is distal symmetric polyneuropathy, which has 3 components: motor, sensory, and autonomic. For each component of neuropathy, there are corresponding diagnostic tools. Each tool tests different nerve fiber functions. Thus, tools complement each other in the examination of all peripheral nerve fiber types, facilitating diagnosis. This is summarized in the following table. Components of distal symmetric polyneuropathy are motor, sensory, and autonomic. Motor neuropathy ensues from dysfunction of myelinated large somatic AA nervous fibers. Impaired function of these results in reduced muscle flexibility and, ultimately, foot deformities, which are one of the major etiologic factors for foot ulceration. Secondly, sensory neuropathy ensues from dysfunction of large somatic A beta and small A delta C somatic. This leads to positive symptoms, neuropathic pain, or negative symptoms, mainly loss of protective sensation. The insensate foot, as realized years ago, is a foot with a very high risk for ulceration. Finally, autonomic neuropathy affects the small, postganglionic C nervous fibers, and the result is impaired sweat production. In this way, the skin becomes dry and can easily crackle, promoting callus and fissure formation. These are common abnormalities associated with ulceration in the diabetic foot. Corresponding diagnostic tools for these dysfunctions comprise, for the motor component, the patella hammer for tendon reflexes, and also devices like pressure stat for the detection of areas with high pressure. For the sensory component, the 128 Hz tuning fork, the 10-gram monofilament, the pinprick, and so on. However, for the autonomic component, there's no simple device, and diagnosis usually includes skin inspection. It is exactly the lack in this area that Neuropathy test came to fulfill. Indeed, today Neuropathy test is the only simple and inexpensive medical device which documents Sudomotor dysfunction and has been validated in more than 30 clinical studies. Neuropathy test contains 2 adhesive reaction pads. Each Neuropathy test consists of a transparent adhesive polyolefin medical film for safe and secure application and protection of external humidity during application, and an indicator pad composed of 100% viscose impregnated with defined anhydrous cobalt dichloride solution, which is the active ingredient. Neuropathy test has a specific and standardized way of use. Its results are accurate irrespective of environmental humidity. Neuropathy test contains 2 blue adhesive reaction pads which are simultaneously applied on both feet under the metatarsal head 1 to 2. If there's a callus or hardening in the area, the test should be applied to the closest healthy area. The clinician can evaluate skin dryness in 2 ways, either by checking the color after 10 minutes as a cutoff method, which is the simplest way, or by measuring the time until complete color change in both pads for the staging of Sudomotor dysfunction, which is more complicated. Test result. If after 10 minutes the color turns to pink, Neuropathy has detected normal skin hydration, and so Sudomotor function is normal. By contrast, if after 10 minutes there is no change in color or partial change in color, Neuropathy has detected abnormally dry skin suggestive of Sudomotor dysfunction. In case the time until color change is measured, no or partial color change after 18 minutes denotes extremely pronounced dryness suggestive of extremely severe Sudomotor dysfunction. Due to the high levels of skin hydration and sweat production in children and adolescents, Neuropathy test cannot be used in subjects younger than 18 years of age. Physicians should also be careful in the estimation of Neuropathy results in patients with other conditions that lead to symmetrical skin plantar dryness, like Parkinson's disease, Fabry's disease, multiple sclerosis, etc., and also medication like diuretics in high doses and SSRIs with strong anticholinergic action, as well as in subjects older than 70 years of age. The ability of Neuropathy tests to detect Sudomotor dysfunction is attributable to 3 factors. First, specific and standardized manufacturing process. Second, quality control and protection of environmental humidity from the impregnation phase until application. And third, chemical properties of active ingredient. The latter is blue dry cobalt dichloride solution, a very well-known moisture indication in chemistry. The only way for Neuropathy to change color is to find the appropriate moisture status in the skin so that each molecule of anhydrous cobalt dichloride will react with at least 6 molecules of water in temperature less than 52 degrees centigrade. In all other cases, the test remains blue or blue-pink, which is denoted as partial color change. The main reason for sympathetic dysfunction in diabetic patients is peripheral diabetic neuropathy. Unfortunately, this represents one of the most unrecognized components of neuropathy because direct measurement of sympathetic nerve activity needs expensive and sophisticated equipment. Thus, so far, the diagnosis has been based on visual estimation of the skin. However, skin inspection can only detect very severe cases. Conversely, Neuropathy test offers to physicians and patients a direct, objective, visual and standardized method to evaluate Sudomotor function. In the next slide, we will see why Neuropathy test response is so important. In this study, all diabetic patients with abnormal Neuropathy test result had structural denervation in the feet. intraepidermal nerve fiber density in fibers per millimeter calculated by skin biopsies compared with age and sex-matched control subjects, group C on the table, was non-significantly reduced in diabetic patients with a normal neuropathy response, group normal on the table, and significantly reduced in patients with a patchy or absent response, group abnormal on the table. Nerve fiber density was correlated with the neuropathy response with a correlation coefficient of -0.271 and a p-value of 0.04. Neuropathy test has the same performance as nerve conduction study. The following table summarizes the findings of time until complete neuropathy test color change, measured in seconds, among diabetic patients with abnormal nerve conduction velocities, with normal nerve conduction velocities, and controls. Differences were significant between the groups. Characteristically, diabetic patients with abnormal results in nerve conduction study need 30 minutes on average to complete neuropathy color change. Neuropathy test is highly reproducible. Agreement in the diagnosis of Sudomotor dysfunction between two neuropathy test examinations is 98%. Intra- and inter-observer coefficient of variance ranged between 4.1 and 5.1%. Neuropathy test results have shown very high correlation between right and left foot, comparable to other diagnostic tools like the tuning fork, tip firm, and 10-gram monofilament. This is extremely important in everyday practice in order to evaluate the symmetrical distribution of neuropathy. Neuropathy test has a standardized, simple way of application with visual and objective final results. Therefore, it is the only medical device suitable and validated for self-examination. There is 90.3% agreement between patient and healthcare provider in the evaluation of the final neuropathy response as normal or abnormal. Patient evaluation of the instructions of use and the test on a 10-point scale is as follows. Easiness to understand the instructions for the use of the neuropathy test, 10 out of 10. Easiness to use the neuropathy test, 10 out of 10. And easiness to evaluate the test as normal or abnormal, 10 out of 10. Today, Neuropathy is the only medical device with more than 30 clinical studies documenting that positive neuropathy test results are correlated with neuropathic level of skin dryness. This chart summarizes neuropathy test studies so far. As you see, there are 21 studies which evaluated neuropathy test using as the gold standard neurological examination, assessment of positive neuropathy symptoms and scores like Neuropathy Disability Score, Neuropathy Symptom Score, Michigan Diabetic Neuropathy Score, etc., or VPT. There are also 2 studies using nerve conduction study as gold standard. There are 5 studies which evaluated neuropathy test using as gold standard classical tests for cardiac autonomic neuropathy like Ewing test and corrected QT. In all studies, there was a high correlation between neuropathy and clinical neuropathy. Of note, in the majority of the studies, neuropathy test has sensitivity more than 84% and specificity more than 64%. Based on these findings, we can come to the following conclusions. In all studies, there were no differences in the final neuropathy results between male and female subjects, or in populations from different countries and even different continents. In positive neuropathy results, the severity of foot dryness is correlated with peripheral diabetic neuropathy. The high correlation proves that the levels of skin dryness which neuropathy objectifies are closely related with abnormal dryness due to diabetic neuropathy. Neuropathy test has higher than 84% sensitivity. This means particularly sensitive results for such a simple, visual and objective tool. Physicians who want a more detailed evaluation of pseudomotor dysfunction can increase the application time of Neuropathy test. The 15 or 18-minute cutoff has higher than 74% specificity. In the following two tables, you see the specificity of different times of Neuropathy test in correlation with severity of neuropathy as staged by the Michigan classification system. Compared with 10 minutes, the 15-minute and 18-minute cutoff values yielded higher specificity. A threshold above 1,440 seconds or 24 minutes yielded 99% specificity for the diagnosis of Class 3 neuropathy. All in all, what is then the utility of Neuropathy test? Neuropathy test is the only validated test for the documentation of foot skin dryness and for the detection of pseudomotor dysfunction. Subclinical pseudomotor dysfunction can be detected early in diabetes, even in subjects with normal nerve conduction velocities. Sympathetic nerve impulses were absent in 64% of patients with diabetic neuropathy compared with 19% of patients who had other types of polyneuropathy. The first prospective study on Neuropathy test confirms the above. A positive Neuropathy result in diabetic patients without clinical neuropathy was found to be a reliable indicator for the development of clinical neuropathy in the future. Thus, detection of pseudomotor dysfunction with Neuropathy test enables earlier diagnosis of diabetic neuropathy. Results are summarized in this table. Among patients who initially had no clinical neuropathy, almost 26% of those with positive Neuropathy test finally developed clinical neuropathy at 5 years, as compared to only 2.9% of those with negative Neuropathy test. Autonomic denervation in the feet is always present in patients with diabetic neuropathic foot ulceration. Pseudomotor dysfunction is associated with increased risk of foot ulceration. An abnormal Neuropathy response correlates with foot ulceration in subjects with diabetes. In this study, multivariate logistic regression analysis after adjustment for age, sex, duration of diabetes, glycated hemoglobin, neuropathy symptom score, and peripheral circulation in the two groups, that is, with and without ulceration, demonstrated that the odds of foot ulceration increased with higher neuropathy disability score, vibration perception threshold, and monofilament in sensation, as well as with an abnormal Neuropathy result. International guidelines include visual estimation of dry skin as a part of comprehensive foot examination. Foot examination should be performed in all diabetic patients at least once a year to identify high-risk patients. All of the above have one major target: prevention of ulceration and amputation in diabetes. This is the main target and usefulness of Neuropathy project. Neuropathy test is a simple, validated medical device with direct and visual results. These features render Neuropathy test suitable for use in primary health care as a screening tool to detect diabetic patients with pseudomotor dysfunction, thereby identifying the largest part of diabetic patients whose feet are at risk of ulceration. Clearly, subjective and uncontrolled visual estimation of dryness cannot replace a standardized and validated medical device. Neuropathy test, the only validated simple test for the documentation of pseudomotor dysfunction. It meets requirements of foot guidelines, sweat measuring, and has already been included in national guidelines and reimbursement status in several countries. It is a particularly sensitive test to identify foot at risk of ulceration in diabetes. It is an objective, non-invasive, validated and reproducible test with direct visual results. It raises patient compliance and awareness of foot complications and the need for regular professional foot examination. It is simple and very easy to use. It is inexpensive. It has been validated for self-examination and education. It is suitable for use in primary care. The first step of Neuropathy project is Neuropathy test, a unique, innovative, validated diagnostic test for the detection of Sudomotor dysfunction and diabetic foot syndrome. The second step is Neuropathy repair foot foam. This is the most complete, effective treatment for diabetic patients with Sudomotor dysfunction as documented by a positive Neuropathy result. All international recommendations include skin care and daily skin hydration to prevent foot lesions in patients with diabetes and dry feet. But is hydration the only need? This photo shows the skin on the sole of the foot from a Neuropathy positive patient, enlarged here for details. Obviously, there are dead epidermal cells, small areas with hyperkeratosis and skin scratches. If this condition remains untreated, callus and fissures will develop in the future, ultimately giving rise to open lesions. This epidermis needs synergic action in order to stay healthy. Keratolytic action to remove dead cells and protect from callus formation, regeneration to heal small skin scratches, hydration to increase skin elasticity and plasticity. Neuropathy repair foot foam is a unique formulation that covers all aspects that dry skin needs to remain healthy. Neuropathy repair foot foam is a unique formulation consisting of 6 active ingredients with synergic action, mainly achieving keratolysis, regeneration, and hydration. The active ingredients and their actions are alpha-hydroxy acids, very well known for years in cosmetology for keratolytic properties. They help remove dead epidermal cells and protect from callus formation. Extract of Centella asiatica, rich in acetic acid, muddicassic acid, aceticoside, and medicassicoside, is used in dermatology to regenerate, recover, and moisturize the skin. Unothera baianis oil, which is rich in gamma-linolenic acid that also regenerates, moisturizes the skin as well as increasing its elasticity. Panthenol and allantoin, very well-known ingredients for moisturizing and hydration properties. Allantoin, which also promotes skin recovery. And finally, 10% urea, which is known to moisturize skin epidermis with mild keratolytic action in order to increase the keratolytic action of alpha-hydroxy acids. Importantly, the foam has excellent galenic properties which offer a safe and effective solution for skin dryness. The pH is 5.5, identical with skin. It is a non-oily formulation, free from Vaseline, paraffin, and ionoline. It enables active absorption. It is free from perfume and parabens. It is dermatologically tested and hyperallergic. It is clinically tested with results as early as after 7 days of application. Neuropathy project enables a move 2 steps forward in the diagnosis and management of diabetic patients with foot at risk of ulceration. The most successful combination for the diagnosis and management of Sudomotor dysfunction in patients with diabetes.